Hello and welcome to episode 4 of Atrainability Radio, where I talk with Sarah Hillman, another of the speakers at TEDx NHS 2019, about her experiences as a woman progressing through her medical career and also moving from a focus on hospital work with originally obs and gynae to now setting up as currently a registrar in primary care. Sarah is a clinician and also an academic researcher, and she works in the Coventry area. And I know we've got at least one friend in common, who is Chris Turner, who has the Civility Saves Lives project going on. Sarah became very interested in understanding the role of gender in medical practice when she was an undergraduate. And she's gone on to complete her PhD, looking at antenatal tests used in pregnancy, and her research interests now lie in women's health within primary care in particular. So we're going to be discussing once again the human factors and behavioural aspects that make for successful days and outcomes in healthcare in her experience and possibly some of the other. Hello, Sarah. How are you?
Yes, very well, thank you. How are you?
Absolutely great. Thank you very much. And how's your day going so far?
Not too bad, thank you. It's early, things can change, but fine at the moment.
So what's the plan for the rest of your day?
Today's an academic day for me. So I'm a general practice trainee, but I'm also an academic trainee as well at the University of Warwick. So today we'll be with having meetings about future research plans and trying to do a systematic review that I'm trying to get done at the moment. So yeah, a bit of academic work today.
Great. So how does it feel now? Are you still on the wave, having spoken at TEDx NHS?
Yeah, I mean, it was an incredible process. It was amazing to be part of something like that. I thoroughly enjoyed it.
I thoroughly enjoyed being there and listening to all the talks. Although I found, I must confess, some of them quite, emotionally draining. And listening to all of them live on the day, it was quite a turmoil, and it caused me to have a lot of time pondering on them afterwards. And so far, we've been lucky to record podcasts with several of the other people. So for the benefit of people listening, could you just briefly, give us a thumbnail of what your TEDx talk was about, please, Sarah?
Yeah, absolutely. So my TEDx talk, I was slightly different to a lot of the other speakers. A lot of the speakers had very personal experiences about who they were, or their journeys, or maybe an illness or an experience within the NHS. Mine was slightly different, and I don't know if you got that feel, Trevor, on the day, but mine actually was a talk about how we should and could be rethinking an idea, and that idea was to do with a term, medical feminism. So I sort of started off by talking about the fact that actually the word feminist wasn't particularly a word that I'd ever identified with previously, and had always experienced an awful lot of support from men personally and professionally, and that actually that wasn't a word I ever felt the need to use. And then I sort of dipped into history and talked a little bit about the Edinburgh Seven. And their experiences. So they were the first women to ever enrol onto a UK medical degree, and spoke a bit about the fact that actually what they came up against, and actually they weren't even allowed to graduate with medical degrees. And the fact that actually while I was at medical school and when I graduated, I never considered that actually that path had been cleared for me actually not that long ago. And then I spoke a bit about the idea of the fact we've got so many women in training now, and that's incredible. And the landscape is changing, but that's actually at the very top, we're still very male heavy, and particularly women in certain roles, such as academic roles, sort of professor type roles, surgical leadership type roles. And why should that be? And then sort of touched on this idea of unconscious bias. And we have unconscious bias about lots of things, but
yes.
but my personal unconscious bias to gender. And then sort of finish the talk really by changing and actually saying, actually this unconscious bias isn't just to do with the women that we promote and put them at the very top of their clinical career paths, but actually this goes much deeper. This actually involves the way that we consider healthcare. And if we start looking at the research that's gone on previously and the idea of medicine and where it all came from, actually, of course, it was very male orientated because that's historically what happened. But actually, if you look at the way we're still doing some research, there's not as many female animal model shoes. There's not as many female participants often, and certainly historically that's the case. And therefore, we have a medical system that has been set up by men for men, and what the implications of that are really, and how we should consider that, and going forwards, what we should think about doing.
Yeah, and I find that very interesting because I don't know if you're aware, my background is commercial aviation. So I was a pilot in British Airways. And of course, when I first joined the airlines back in 1971, it was, I think, totally male dominated. And I can remember the first lady pilot to join BA and the British Airways, and the consternation that seemed to cause. But ironically, for me, I started flying as an air cadet when I was 17, and I was taught to fly at the flying school on a flying scholarship by a lady pilot who forever, her name Rosie Stevenson, and she was about 5'0" and sat on a cushion and sent me off on my solo, and and that was I think that helped me a bit. But I can remember, if I'm absolutely honest, having this sort of, as you say, almost conscious bias, because it was such a male-dominated profession. Yeah, so, I mean, are there any instances where it hampered you yourself? Or
well, have I got experiences? Well, I suppose...
reverse, where people have actually, I don't know, felt...
been positive about it. Well, I suppose I hadn't really considered that I'd had many until... probably my life changed and I became a mother. And I think that did change a little. My husband and I both went to medical school together. And we graduated together, and we started our career paths at exactly the same time. But just to sort of put it in perspective now, he is a consultant who is the lead of a large unit in a tertiary centre, and I'm still in training. Part of that came from the fact that I decided to make a career change. So I was originally training in obstetrics and gynecology and was training to be an academic, but some things changed and something in me changed. And part of that was taking time out to do research, and part of that was the change in my family circumstances. But I changed to training as a GP. I have redone parts of my career path, but consequently now I'm at I'm still regarded as a junior doctor, obviously a term that a lot of us have problems with because it can span a whole depth and breadth of experience that doctors actually have. But I still have that term, and I still am called a trainee, and that will be the case until I get my certificate of completion of training next year. But I've become increasingly interested in what happens to women in careers and their career pathways because of what's happened to me. And so because of that, I've been involved at the university with something called Athena Swan. I don't know if you've heard of, have you heard of Athena Swan,
No, I'm
Trevor?
afraid I haven't. No, please explain.
Yeah, so Athena Swan is essentially something that higher educational institutions, so all universities, apply for to look at how they are considering particularly gender in their career pathways. And as an institution, what you're putting into place. Well, firstly, to look at your career pathways, what's actually happening to people and where do we lose people? So we know that we put lots of women in at the sort of junior academic levels, but what happens to them and why aren't they professors at the end? And what are the stumbling blocks? Where are the points that we lose women? Why are we losing women? So Athena Swan is an important vehicle, really, for trying to understand those reasons and then do something about it. So you apply for this and you either get a bronze, a silver or a gold type award. And lots of very influential funding bodies, for instance, the National Institute of Health Research, has started waking up a little bit to this and saying, well, actually, unless you're an institution that can show you doing this, we don't really want to be sending extra trainees to you. We might not even want to be funding your research anymore. So suddenly, for institutions, this is something that we really need to think about. So I've been involved in Warwick Medical School's application, and we're really lucky. Well, not lucky. We did a good application, and we received a silver award this year. And what that means is that we showing that we not only are we thinking about change, we're starting to implement it. So part of my journey, really, and towards the TEDx talk was personal experience of starting to look at women and why these sorts of things happen. And another part of the work that I've been doing recently, I think, that's made me start to think about this, because obviously as a woman I've come across the concept of having a family and how that changes the career dynamics for women. But then another thing that I hadn't really considered, but starting more and more, I'm starting to hear a lot more about, is the menopause, and how women, when they're at that particular stage in their life, the sort of the barriers that they can come against in the working environment, and what we do to help women at that stage as well, which was something I'd never really considered before, but of course is so important, because we've got women now who are often at the peak of their careers. The mean age of the menopause is 51, and we have we're trying to make sure that women are getting to those senior type positions, and then so we've got a whole host of women that are really at the pinnacle of their careers at this ages, and then suddenly they hit menopause, and what happens to women during that time as well. So there's lots of things that I think we could be thinking about and doing better for women as employees.
Is there are you actually practicing as you're not fully qualified yet, but as a GP? So, but presumably you'll have spent time in primary care and interfacing with patients. Is that
absolutely
something that you found your thoughts and understanding on this has helped?
Yeah. Oh, absolutely. So I do 2 days a week in general practice. And the rest of the time I'm at the university. So I'm doing general practice clinics, and I'm a GP registrar. But because of my women's health background and because of these interests, I do see a lot of women, because they're either signposted to me or they've heard from a friend, or these things happen. But I see an awful lot of ladies that suffer with female complaints, polycystic ovarian syndrome, endometriosis, this sort of thing. But what I see an awful lot of is women between the ages of 45 and 60 who are going through that menopausal stage, and how that has changed. How they not just, we speak about the menopause, don't we? We speak about women having hot flushes or being sweaty overnight or that sort of thing. I think what we don't talk about an awful lot more is the other things that these women have. So during that time, they often have an awful lot of anxiety. Some women, their mental health gets a lot worse. They have massive decreases in their confidence. They feel that they can't cope. And not only is this having a big impact, of course, on their work. So I see an awful lot of women coming in saying, I can't work at the moment, I'm just not coping. But also has a big impact on their family life as well, because these are women that often are trying to juggle everything. They've got loads of balls up in the air, and suddenly they're just not holding it all together. So that has a big impact on their relationships with their partners and their children as well. So and of course lots of women come with other symptoms of the menopause, which we don't normally always associate with having the menopause. For instance, women sometimes just come in saying, God, everything aches, everything aches. Or other things that we just don't talk about so much. So talking about libido, for instance, women don't necessarily volunteer that information unless they're sort of asked. So, yes, I'd say my interests as an academic interest as an advocate for women's health definitely has a big impact on my clinical work as well. And hopefully, she says, goes on to benefit the women that I see in clinical practice as well.
Sure. And it must be something which is a major problem across primary care then, because I don't know the figures, but are the majority of GPs, are they male? Or I think my practice is probably about 50-50, I think.
Yeah. No,
I don't know. Dictate how which GP you go and see if you have a specialist, in women's health in your practice, so much the better. If you can get to see them, of course.
Yeah. So I don't know the figures either. I mean, I think that actually the proportion of GPs might actually be now more female. But I don't know that for definite. But no, you're quite right. And in an awful lot of practices, there will be a GP or two that definitely have an interest in women's health. Just as in an awful lot of practices, you have somebody who has a special interest in dermatology or musculoskeletal or doing minor operations. So, we're all trained to be expert generalists, but we do. Often you will find in most practices you'll have somebody who has a specialist knowledge about something, and that's always worth trying to find out actually as a patient, I would say, because you're getting the right person for your complaint really. And I've thoroughly enjoyed my training, and the support that I've received has been phenomenal actually. I spent an awful lot of time considering the change from what was a surgical specialty really to general practice, and whether that was something that I should do. It wasn't an easy decision. It's probably the biggest decision I've ever had to make. And once I'd sort of wondered whether I should make that decision, I sent a couple of emails. I didn't know anything about the sort of GP landscape at the time, so I didn't know who I was emailing, but my husband suggested that there'd been a local GP who was very good talking about training. Maybe I should email her. So I emailed somebody called Dr. Catherine King, and then I Googled academic general practice Birmingham, and a name popped up, and I also Googled Professor Stokes Lampard. So I emailed both these people on a Sunday afternoon. Both responded to me on a Sunday afternoon and said, come meet me. So I met Dr. Catherine King and in her practice in Stratford, and we spoke about my set of skills and the move to general practice. And she was incredibly positive about the change, and that I wouldn't be the first person who's made that switch, and that I could take those sorts of hospital skills into general practice, and that actually that's really important. And then I met up with Professor Stokes Lampard, and I spoke to her about academic training, and I said, look, I'm a clinical lecturer in obs and gynae, and she said, I was in obs and gynae as a trainee as well. I made this move. You can move, you can take these academic skills with you, they're needed. And she was incredibly inspiring. What I didn't know previously, and actually what I think was good that I didn't realise, was actually that these women were incredibly important in the GP leadership landscape. So Dr. Catherine King went on to become Director of Postgraduate General Practice Education. She's now in charge of general practice education for every GP in the whole of the West Midlands.
Wow.
And of course, Professor Helen Stokes Lampard went on to become the Chair of the Royal College of General Practice.
Yeah.
So both of these women must have been incredibly busy. And they got an email from somebody that they just didn't know on a Sunday afternoon, and both responded and changed my career. And I still, there's times now where I get emails from people and I don't, think, oh, well, I've got a lot on, and shall I respond? And the fact that those two women reached out to me at that point in my career when I really needed it most means that now when I do get that email saying, I'm not sure, I don't know whether I should do this, can you help? That actually you do reach back out actually. And I think the more senior we get, sometimes we don't understand that, those quick conversations, that email, how influential they can be actually for people's careers going forward. I don't know if you've experienced things like that, Trevor, but I don't know. I found that I still find those women very much so, very inspiring.
Very much so. But what was coming on my mind there was that those are the attributes of those real standout leaders. So it's hardly a surprise that the pair of them have achieved such high levels as they have, because they are they're walking the talk. And those are really important things. So it's just something that occurred to me. You're talking about taking your hospital skills and knowledge and understanding into the world of primary care, and that's something we've kind of come across, is this almost schism between primary care and the acute sector, where obviously we train teams right across the piece, community, acute, and primary care, and we're about to start working with a primary care situation in another part of the country where they've I think it's a forced merger of two quite different GP practices, one that's in quite a how can I put it, an upmarket situation, and the one they're merging with is the other end of the social spectrum. And it sounds like the issues, why they've asked us to come in and try and help them, is that the attitudes are quite different. One sees themselves as being better than the other, and is very well resourced, high quality equipment and nice decorations, smart place, and the other one is very much not. And this is going to be a really interesting challenge to understand each other and to work together. But even at the partner level, it sounds like there's a bit of an issue. So yes, I'm looking forward to that. But this, have you seen that there's a kind of a split of understanding almost between primary care and the acute sector?
I think there still is, in terms of, there still is, unfortunately, Trevor, this idea of, is it prestige? Is it, I don't know, the idea that as a doctor in training, that if you're really good, you'll become a hospital consultant, or you'll become a surgeon, and that actually, if you're not, if maybe you decide that you're not so good, or actually you've got other priorities, that maybe you'll go into general practice. And actually, so I had a lot of comments when I decided to change from various people. A lot of them were family and friends, saying things like, well, yes, you're a mother now, so maybe your priorities should lie elsewhere, almost as if there was this idea that I was somehow giving up. And I found that incredibly frustrating. An awful lot of my friends who are mothers and doing wonderful jobs as general practice partners said to me, do not move thinking that this is in any way an easy move. You're going to be doing very long hours and it's stressful. And so I went into this very much with my eyes open. My experience of general practice has been that I've been fortunate enough to be training with some of the best generalists that I've ever had the fortune to come across. These these doctors are highly skilled. In 10 minutes, they don't have a letter. We don't know what these people are coming in with. You've just no idea. Somebody will come in with a complaint, and actually that might not even be what they've come in for. They might even just have a complete hidden agenda, which you need to extract. Or they might come in with a whole list of problems, or they might actually come in because of something that's not even medical at all.
Yes. And
I have seen firsthand the way these wonderful doctors communicate with people, and how one of the things that I've had in general practice again is really joy in rethinking the idea of the consultation and how we communicate with people, and how we get that relationship and get people to trust us to tell us everything that's going on. And the other thing I think that's another thing I really enjoy is the idea of continuity. And sometimes you don't get that quite so much in hospital medicine, but the idea that not only do you have the continuity of knowing the patient, but you often have the continuity of knowing their entire family.
Wow.
And yeah, and there's been other things. I knew I was going to very much enjoy the women's health sort of perspective and things, but there's so many new skills that the good general practitioners are experts in palliative care in people's homes. And I don't think we fully understand the fact that if you've got a really well-trained GP, people are dying in their own homes, and how important is that?
Yes.
You know? Yeah. So I am very much feel that very much now I have found my place, found my career setting. I'm very enthusiastic about general practice as a career, and the fact that it should not be seen as something that comes in any way second to being a hospital doctor, because the doctors that I've come across not only are highly skilled, but they're massively committed, and that we should be telling that story, really.
I think that's fantastic. See, today I'm on the PPG, the Patients Participation Group of my GP practice. In fact, a little bit of argy-bargy because they've changed it to Practice Support Group, which in my mind means something slightly different. I like the idea of being a critical friend, and it's the critical bit that they seem to be slightly uncomfortable with. But in our practice, and we're in a rapidly growing semi-rural area here, it's very, very difficult to get to see the same GP again. Even my own GP, I occasionally see him walking down the street. I mean, I'm lucky. I don't go to the GP very much. I'm touching wood furiously here. But continuity is something you mentioned just now, and that's something that we're having trouble with in this practice. And I think they're also having trouble with keeping people down to a reasonable consultation time. Absolutely. Again, you said people come in with multiple things, and of course the tendency is to say, okay, you've had your go, now, make another appointment and come back later. So are there any, what I was thinking was that practice managers can have a huge impact on how a practice runs. Are there any examples of particularly good behavior or systems, good systems that you've come across?
Yeah. So I agree with you, Trevor. I mean, I think the Royal College of General Practice is aware of this, and this stems from lots of things, but a lot of what it stems from is the fact that general practice has been under-resourced, as has the NHS for quite some time, that we don't have enough GPs, and there's been lots of policies to try and increase the number of general practitioners. But I recently attended the RCGP annual conference, and we started looking there at figures of doctors in training. And although there has been a percentage rise in doctors in training in general practice, it's still half the amount that the increase in doctors in specialty medicine, in hospital medicine.
Gosh.
So we're still, even though we are increasing in numbers, it's nowhere near as fast as we need it to. There's other things as well. I mean, we have increasing patient expectation. I'm not saying that's a bad thing at all, but what that does mean is that the average person is consulting an awful lot more than they did 10 years ago.
Right.
So where you may well not have gone and seen a GP about something, people now do, and there's lots of reasons for that, as well as increasing expectation. Perhaps it's that you don't quite live in the family type setting that you used to, and you can't get the information that you needed to from maybe a mother or grandmother or grandfather or those types of situations. And the other thing, of course, is that we are increasingly getting good at treating things, which means that no longer do we say, well, actually, just live with it. We say, well, actually, let's try and see what we can do about this. So there's lots of reasons. And of course, we do have an increasing age ageing population,
Sure.
and that population comes with its own challenges, of course, things like polypharmacy and polymorbidity, which means that actually those consultations are actually often really complicated. They're very rewarding as well, and they're very intellectually challenging for us, but they probably take longer than 10 minutes.
Yes.
So there's plenty of reasons why that continuity doesn't exist as well as patients would like, and as well as GPs would like. We love continuity. It gives us our back what we put in, because if you see somebody and you make a change and then they come back and they tell you they're getting better, that's fantastic as a doctor. That's what you want to hear. So I think we're losing out as well as patients, interestingly.
Yeah, that's got to be something which really matters, isn't it? About following the patient through, because you don't get that feeling of kind of satisfaction of
yeah, sure.
seeing the task all the way through. I can totally understand that. You're just saying about the polypharmacy. So one of my friends, I'm in the Lions Club, one of my friends in the Lions just emailed me this morning with a comment, and he said, "Oh, by the way, I've just got my mother back from hospital, and she was on 27 different medications.
Wow.
I've got it down to 7. And that tells you a whole lot. And in terms of waste in the NHS, doing that, it would pay back, wouldn't it? It would got to be a huge reduction in cost, as well as the potential danger of comorbidities and whatever.
Yeah, absolutely. So we spend a lot of our time talking to people about medications, taking out things that they don't need, or sometimes, I mean, the thing is, not only are we prescribing and distributing 27 medications, but actually, how much is the patient actually taking? Yeah. And therefore, what's that sort of wastage? But not only that, if people, for instance, aren't taking their 3 antihypertensive medications, they come into the GPs, they have their blood pressure and it's still high, but they don't tell the GP, and then suddenly they end up on a 4th, So I think that is something that we are trying to tackle. And there is an idea, I don't know if you've come across the idea of primary care networks.
I've heard of them, yes.
So that's the sort of change that's happening at the moment. But essentially, you talked about the merger of 2 practices, and this isn't about mergers, but it is about practices working together in geographical areas. And part of the reason for that is that actually what we then can do in this network is employ people that might help. So not just one person that would help one practice, but potentially an allied healthcare professional that would then help a group of practices. And we are employing community pharmacists to help a group of practices to try and tackle some of the things that you've just been talking about. So actually looking at some of these patients with loads of drugs and look at where it can be cut down. It doesn't necessarily have to be a GP's work. One of the other things these primary care networks are doing is employing a social prescriber. And I don't know how much you've come across that as a concept, but the idea that actually an awful lot of GP consultations are taking up with patients coming to ask about things that aren't medical. So, can you help me with my housing, doctor? I'm really struggling with money at the moment, doctor. And of course, all these things have massive impact on people's mental health. Yep. So, and often their physical health as well. So they're incredibly important. But again, and of course, one of the other big things that we have, that we see an awful lot in general practice, that I don't think we always pay enough attention to, is loneliness. And social isolation, and actually the fact that when you've got people that are lonely and living on their own, what massive impact that has, not only on the person but then on their physical, mental health, and therefore the visits that they make to the GP. Or other allied healthcare professionals. So one of the things these social prescribers are doing are signposting people to things in the community that they wouldn't necessarily know about. So, physical activity type groups and things.
Well, that's a very interesting one for me, because our Lions Club here is very, very involved with the community. We're one of the growing Lions clubs. And of course, there's also Rotary, and they do very similar stuff. And some places have round table, which we don't have. But those sort of volunteer groups, we're actually finding it difficult these days to get in touch with the people in the community who we could help. So we do things like food parcels at Christmas, and if we have a plea for, I don't know, single mum needs a carpet, she's been rehoused, there's no carpet on the floor, and can we save the potential of the kid falling down the stairs on concrete stairs? And that's the sort of thing that we try to do very much, as well as obviously bigger things. But it's difficult these days to actually get the contact because of the demise of sort of social services and shortstop and whatever, to find out where the people are. And everyone's worried about privacy and confidentiality. And it's we have, for instance, here, we can't be unique. There's this huge potential to help exactly what you're saying, social prescribing.
Absolutely.
And yet it's difficult to get it. I'm going to bring that up in the PPG today. That's
I would, definitely.
Yeah,
good.
Are there any sort of summary messages that you'd like to get out there in particular? It's been fascinating.
Well, I suppose really that in these times of austerity, in these times of, particularly we hear an awful lot in medicine about burnout, we hear an awful lot about low morale and things, but there is definitely an awful lot of good, positive things going on. There is the standard of training for your local GP, I can tell you, is brilliant, is excellent. We've got a lot of brilliant, enthusiastic young doctors coming through, and I think the future looks bright. But sometimes we just need to think a bit outside the box.
It does actually. It's a very, very quick trigger in my mind then. So that my company does human factors training, or particularly behavioural awareness raising and things like that, of the way you interface with people. And a very simple one for anyone is avoid, if you possibly can, leading questions, as in, you don't have any allergies, do you? Or you are taking your medicine, aren't you? And all those things. And I mean, have you come across that being trained? Is that included in the training?
Absolutely. So we undergo an examination, clinical skills assessment, and for that exam, you go down to the Royal College and you have 13 10-minute consultations, and your examination, your consultation style is scrutinised. And one of the things that of course is something that is a big no-no is those leading questions. But along those lines, I was at the dentist last week, and the dentist said to me, what did she say? I think she said, "You don't drink much caffeine, do you?" And I said, no, or alcohol. And then she said, "Maybe a little." And I went, "Yep." So it just showed me, if you lead question and you or occasionally and you give people the opportunity to opt out, they will. I did.
well, on that note, have you ever had the wrong patient in your clinic? Because we hear a few stories of where, and they've gone, next, or Mrs. Jones, and in comes Mrs. Jones in there, and you're sitting there and you think, hang on a minute, this doesn't look right. And I know one doctor who told a woman, so how long has your mother been, I don't know, something like, an alcoholic, diabetic, and something else. This woman nearly fell through the floor. And it, just to cut a long story short, turned out there were two women in the same street, who one lived at number 34, the other lived at number 43. They had the same name, and their dates of birth were transposed. So 5/1/34 and 1/5/34, something like that. They didn't know each other, and she'd got the wrong one.
Yeah.
And it's so easily done.
Easily done. Yeah. And so no, not in general practice. I did once try to take the wrong father into the wrong labouring woman, but luckily we didn't get quite as far as actually getting in there before we established that it was the wrong mother, thank goodness. But that's another story.
Very easily done. Well, my wife went in to have a procedure in a private hospital, and they told me to get undressed and get into bed. I thought that was most impressive. I didn't know.
Thanks very much, Trevor.
Oh, Sarah, it's been an absolute pleasure, and thank you for your time and your insight. It's absolutely marvellous.
Thanks for your support, Trevor.
Oh, brilliant. Thanks for yours. All right. All the best, Sarah.
Okay.
And good luck.
Okay,
Bye.
then.
Bye now.
Bye.
So, Sarah Hillman, that was a really, really enjoyable and interesting conversation we just had, and a lot of insight, and I think a lot of encouragement. We hear so much about what goes wrong with the NHS. Sarah seems very optimistic about the future and the way things are heading, and I think with people like that around, let's look at the glass being half full. I think so many people are trying to bring it down, and yes, we know it's under-resourced, and yes, we know times are tough and it's incredibly stressful, but there are ways of getting it right, and there are, I think, hopefully quite a number of beacons, if you like, of optimism and excellent practice and great ideas, which we hope to share, and let's hope there are more of them. So thank you for listening, and we'll be back with more podcasts in the near future. Thank you very much, Sarah Hillman, and thank you to you for listening.